All right, why don't we go ahead and get started and we'll let folks trickle in. I realize I'm between everybody and lunch, so it's been a nice morning of some great presentations so far. So my name is Erin Taylor. I'm a senior policy researcher at the RAND Corporation, which is a nonprofit, nonpartisan research organization. And as the title of my talk today might give a hint, I tend to focus on research in the Medicare area. My particular area of interest is on benefit design, so in private healthcare plans like Medicare Advantage and the Part D plans, which I'll talk a little bit more about in a minute. But I am especially interested in the effect of cost sharing for patients and how much they're able to access their care and their utilization of care, and then downstream health outcomes associated with that access to care. So I'm going to talk today specifically about accessing Medicare data, but I want to highlight that this is sort of perhaps more broadly applicable to those of you who are thinking about accessing administrative data more broadly from other sources. So I'm going to dig into the details here on how it might work for you if you want to go after Medicare data for your research, but just think that there might be some parallels in how you access other data. So a few learning objectives for today, and then I'll dive into the details. So what types of Medicare data are available to researchers? What research questions can Medicare data help address? And then finally, how can researchers access these data? And I'll do a deep dive, especially on the research identifiable files, because those are the most difficult data to access. So I thought that the first presentation today, he threw up that little hand-drawn diagram of all the little Medicare data things. That one resonated for me. So let me give you a little brief tour of the Medicare program so you understand what I mean when I start to talk about the data. So Medicare provides insurance coverage for eligible individuals who fall into a few different categories. So you can be eligible for Medicare based on your age, those who are 65 or older, disability if you're under age 65, and then some specific condition-specific eligibility requirements. So for example, end-stage renal disease or ESRD, and then those who have amyotrophic lateral sclerosis or ALS, which is sometimes called Lou Gehrig's disease. Those people are also eligible for Medicare. Medicare is administered by the federal government. The first stage is eligibility, and that's determined by the Social Security Administration. And then once you're determined eligible for Medicare and you start to receive benefits, those are administered by the Centers for Medicare and Medicaid Services, or CMS. To give you a sense as to how many people we're talking about, if you're interested in thinking about generalizability beyond just the Medicare population, so 50.8 million people have Medicare in 2023, so a sizable portion of the US population. So Medicare has 4 parts. Part A is inpatient hospital in general and also skilled nursing facility and hospice care for those who elect hospice care. When you become eligible for Medicare, you're considered to be entitled to Part A, which means you receive it automatically and you don't pay a premium. Some people who are not entitled to Part A can choose to enroll and they pay a premium. Medicare Part B, which tends to go along with Part A and has the same eligibility requirements, covers professional services, so in your provider or physician's office, outpatient hospital, emergency department, and so on. You are eligible for Part D, and you are automatically enrolled in Part B. And you can choose to opt out if you choose to opt out. And you pay a monthly premium if you enroll in Part B. So it's been about $140, $160 a month for the last few years. Part C is where private insurers like Humana or United Healthcare, Kaiser, or Anthem come in and they offer coverage of the Part A and B benefits, but they administer them for people who choose to enroll in that plan. So CMS pays those plans directly, a per capita amount per month for beneficiaries who choose to enroll in a Medicare Advantage plan or MA plan. MA plans are also allowed to offer additional supplemental benefits that regular Medicare does not cover. So for example, hearing aids or dental coverage. There's a lot of controversy recently about MA and whether the government is paying too much. So there's a lot of researchers doing some very interesting work looking at the differences between MA and regular or traditional Medicare. And then finally, kind of my favorite part of Medicare is Part D, which provides coverage for prescription drugs that are dispensed at retail pharmacies. And Part D coverage is again provided by private insurers who either loop in the Part D coverage with the Medicare Advantage plan or offer a standalone plan that acts alongside traditional Medicare. So Medicare has a range of stakeholders that all generate a wealth of administrative data for use in research. So CMS over there on the left-hand side establishes rules and regulations and payment schedules and so on for the providers who provide the care, the insurers who receive payment and then in turn administer benefits. Also, pharmaceutical manufacturers have increasingly become an important aspect of interactions between CMS and related to prescription drug pricing and price negotiations. So I threw them on there. And then finally, beneficiaries who utilize the care and have associated claims and so on related to their care. So a brief tour through the types of Medicare data that are available for research. Medicare data fall into several buckets that I'll dive into in a little bit more in the following slides. So there's beneficiary level data, there's provider data, health plan data, and then model test data. So the beneficiary level data provide a wealth of information on all of the Medicare beneficiaries who receive coverage from Medicare. So they fall into sort of three general buckets that I've created. Demographic, so you have information on the age and gender, race and ethnicity, mortality, so did they die in the past year or several years, chronic conditions that they've been diagnosed with, also enrollment, so are they enrolled in traditional Medicare or Medicare Advantage? Do they have a Part D plan and so on? And how has that changed over time? So beneficiaries are allowed to change plans over time. Second, the wealth and bulk of information is utilization. So these tend to be in the claims data for traditional Medicare. MA has encounter data, which provides much the same information. And then Part D has what's called Part D event data, which is dispensed prescriptions. So there's information on diagnosis codes for the utilization, for the healthcare claims, excuse me. So what was the primary diagnosis associated with that particular visit or inpatient stay? There's a whole host of other options for entering other diagnoses that the beneficiary may have or has ongoing. The services provided, did they receive surgery? Was it an evaluation and management visit at the provider and so on? Was a prescription drug dispensed under Medicare Part D and covered under Medicare Part D? Medicare Part B as in boy actually also covers prescription drugs that are administered in a physician office or an outpatient hospital. So you would see in those claims whether any of those drugs were administered. And then finally, what interests me most are costs. So how much did the patient pay, or how much was the patient supposed to pay? How much did the health plan pay? What did Medicare pay? And so on. And then finally, survey data. There's a wealth of survey data on Medicare beneficiaries that ask about their experiences of care, for example, in the Medicare Advantage program or Part D. Also with hospice, so they ask caregivers of those hospice decedents about their experience with hospice. A lot of these surveys also ask beneficiaries to rate their providers, which then feeds into a lot of the quality measures that I'll talk about in a second related to the providers. So the provider data provides a whole lot of information on those providers who have chosen to accept Medicare, which means that providers have chosen to accept Medicare beneficiaries and accept the Medicare payment as payment in full for the services they provide to those Medicare beneficiaries. So some providers, there are certain types of providers that do not accept Medicare, or certain types of providers that might be more likely to not accept Medicare. You wouldn't necessarily see them in these data, but you will see the vast majority of providers in the US who do choose to accept Medicare. So you can have information on their location. So where is the hospital located? what physician group is that physician practicing with? Are they practicing with multiple groups, for example? The type of provider, their specialty, and so on. There's also a lot of information on cost and use. So rolled up to the provider level, for example, it provides information on the payments amounts for services provided, the number of services provided by type of service, and so on. And then a whole wealth of quality measures. So how well do these providers or have these providers done in providing sort of process care measures, for example? So do they order a test for high cholesterol when they should be ordering a test for high cholesterol? And then another of my favorite data sets are the health plan data. So there's a lot of information out there on the benefit packages provided by these health plans. So what services are covered, and if those services are covered, what is the cost sharing associated with those services that beneficiaries need to pay? There's information on enrollment, so rolled up information by health plan on how many beneficiaries were enrolled in that plan in a given month and a given year, and you can track that over time and see changes. Information on the service area for the plan. So some plans operate at the county level or the multi-county level. Other plans operate at the state or multi-state level. So it's nice to be able to tie some of the outside data that I'm going to talk about in a second to the service area that the plan is operating in. Health plan data also include quality measures. So there's actually a whole star ratings program where the RAND Corporation helps CMS calculate the star ratings each year for the Medicare Advantage and Part D plans, and they're posted to the Medicare Plan Finder to help beneficiaries find information about their plans and select a plan that they might like to enroll in for that year. And the star ratings are 1 out of 5 for their 1 to 5, sorry. So some plans get a 5-star rating, which means they're of the highest quality. And then there's different domains within that. So a rating of provider, again, some of those process measures of care, do beneficiaries in that plan tend to get, are they more likely to be adherent to some of their medications and so on. And then finally, there's also information on formulary coverage. So what drugs are covered under the Part D plan and for what cost. So Part D plans are not required to cover all of the prescription drugs out there, but they have to meet certain requirements. So you can take a look at the different kinds of variation across plans in which drugs they've chosen to cover. And then also information on networks. So Part D plans can establish pharmacy networks where you might pay less if you go to CVS as opposed to Rite Aid. And there's information on that. So you can see where beneficiaries might pay more if they go to a different provider or pharmacy. The MA plans also have information on their provider networks. And then finally, there's this kind of category of the Medicare data that's related to model tests. So when the Affordable Care Act was enacted back in 2010, it created a new center at CMS called the Center for Medicare and Medicaid Innovation, which I'll call the Innovation Center for short. And they, over the past 10 plus years, have tested a range of models which are designed to see what is the impact of changing certain aspects of Medicare on access to care, quality of care, and costs. And the idea is to have sort of a small little incubator to test these ideas before taking them large scale and suggesting that Congress go and enact this as a change to the law. So there have been a number of bundled payment models where to see where if we change from sort of paying for all these different services separately, we bundle them together into an episode of care. There are 2 models that are running right now that I'm actually part of the evaluation team assessing the effects of those models. One of which is the Part D senior savings model, which is testing the effect of lowering insulin cost sharing to a maximum of $35 a month. Folks might have heard about that one because Congress decided before we could finish evaluating it that it was such a great idea. They should just go ahead and apply it to everybody. And there's also talk now of applying that to commercial insurance as well. And then the second model test that I'm working on is the Medicare Advantage value-based insurance design test, which is testing sort of a whole suite of different changes to Medicare Advantage to try to target services, supplemental benefits, and lower cost sharing to specific populations of beneficiaries within these plans. So those who have certain types of chronic conditions or who are lower socioeconomic status, to try to sort of get those targeted benefits to the people who might need them most. So there's a wealth of model test data that CMS has just recently started releasing related to participation in these model tests and the beneficiaries who are eligible for the benefits in these model tests, which they're making increasingly available to researchers outside of those of us who are evaluating the model, to allow others to explore and answer some interesting questions related to what's going on within these models. So before I dive into how to actually access the Medicare data, I did want to note that in a lot of the work that I do related to Medicare data, I often use external data sources that are actually generally publicly available. And I merge those in with the Medicare data files that I'm working with. So the first that really comes to mind regularly is the Area Health Resources File, or AHRF. It provides information at the county level on demographics of the county, median income, race, ethnicity, population. It has information that allows you to calculate indices like the social deprivation index and so on. It also includes provider information. So for example, the number of clinicians of certain specialty types that are in a given county, in case you're interested in understanding questions related to access to care in a given place. And then the second is the Health Resources and Services Administration, or HRSA. They track and register health professional shortage areas. And I usually deal with two: the primary care shortage and then mental health shortage areas. And so that's a nice source of data to pull in if you're interested in trying to stratify some of your work, thinking about whether beneficiaries are located in a shortage area or not. Generally, and in case I forget to note this later, as part of your application to access Medicare data, you have to tell CMS that you're going to plan to merge these data in. So you have to be thoughtful in advance as to what exactly you want to do and what data sources you might want to pull in, because CMS wants to know what you're going to do. So as an example of some research questions that you might want to think about answering with these data, I just think there's just so many and there's so little time, and there are many, many people working on a lot of these great questions. The first, which is near and dear to my heart: how does cost sharing affect access to healthcare? I already talked a little bit about what I've done related to that. The second is, what is the effect of Medicare payment models on access, quality, and costs? So talked a little bit about how the Innovation Center is really focused on testing these models in order to answer this question. The third is, are there inequities in access to care across different Medicare beneficiary populations? So actually, as an example, a recent small project I did as part of the evaluation of the MA VBID model was to think about whether participating plans selectively chose to enter certain areas of the country based on whether or not those areas of the country sort of are have more socioeconomic sort of differences. And I'm not sure I'm allowed to say what we found, but actually it was kind of good news. It suggests that CMS is moving in a good direction related to health equity. And then finally, how has the response to the opioid epidemic affected Medicare beneficiaries? So the talk we had first thing in the morning, he alluded briefly to that downturn in life expectancy for lower income people around 2011, and that there's a correlation with the opioid epidemic. So I've actually done quite a bit of work lately thinking about opioid prescribing in the Medicare population and the effect of state policies on opioid prescribing. And then more recently, thinking about access to medications to treat opioid use disorder in the Medicare population and at specific substance use disorder facilities. Actually just had a paper released this morning looking at dispensing rates of methadone in Medicare after a policy change. So Medicare actually finally started to cover methadone for the treatment of opioid use disorder in 2020. So we were able to look at trends in that in the first few quarters after that change. So a lot of really interesting things, I think, to do. Before I dive into accessing Medicare data, I often feel when I talk for like an hour straight, it's kind of awkward. Does anybody have any questions? Or I'm also happy to, yeah. Yes. Excellent question. Uh, First, semi-joking responses. I always smile when I hear healthcare system because there's no real one healthcare system. That's obviously, there's just so many different systems, right? Excellent question. So right, once you're determined eligible, which is, the 65 and over, or you're disabled, and SSA determines disability, or you have those couple of conditions that might make you eligible. You get Medicare Part A, so inpatient hospital, skilled nursing facility, hospice for no premium, no monthly premium. But if you go and use the care, you will have to have some out-of-pocket costs. Like you'll have to meet a deductible, and then you'll have some daily costs after you meet certain thresholds. Part B, you have to pay a premium every month. It's actually higher for those of higher income. And Part D and Medicare Advantage, something similar. To the low income point, if you are low income and you also have Medicaid, and so you're dually eligible for Medicare and Medicaid, you don't pay those premiums and you pay much lower cost sharing. So Medicaid helps fill in the gaps. For Part D, for your insulin example, beneficiaries are able, if you're dual eligible, you're considered you receive the Part D low income subsidy. And more people beyond just the dual eligibles can be eligible for the low income subsidy. And in fact, the Inflation Reduction Act last summer just expanded eligibility. I think actually instead of being, say, partial low income subsidy, you now receive the full subsidy. So they're slowly working towards expanding that. And those beneficiaries tend to pay no premiums for their Part D coverage, and they pay very, very low copays. So it's the $35 max for insulin. Actually, it's quite a bit lower than that for those beneficiaries. But it's a very complex system to navigate. Yeah. Yeah. And do you mean, so within Medicare, there is sort of a single definition of if you receive a given service, any given Medicare beneficiary, unless you're low income and not really having to pay, would pay the same copay. Is that kind of what you mean, or is it, yeah? The main difference in terms of, in this case, income is with establishment of the premiums for Medicare Part B is in boy and Part D is in dog. And so people with very high incomes or, very high incomes per year end up paying more. But that's the main difference then on premium. Okay, so the really fun stuff, which was much of my life it's been my life for years, but especially in the last year, trying to get access to the data for that methadone paper, or related to that methadone paper. So I think about Medicare data as having 3 different levels of access restrictions. So the publicly available data, you could go right now to the website, click download, and you've got it. You're done. And well, now you have to go figure out what you're going to do with it, but you have it. So it's the easiest to access. It's free. There's no barriers to your being able to get it. The second sort of middle one is limited access. So you have to go through a few more hoops. You might have to pay a little bit of money, but it's not quite as hard as the research identifiable files, or the RIF files, which require a fairly substantial amount of time and money in order to show CMS that you are a researcher doing valid, meaningful work and that they should trust their data in you. So I'm going to dive into each of these a little bit more in turn. So there's variation across government websites, and full disclosure, I used to work for CMS, so I'm a little bit biased, but I actually think that the CMS website is pretty cool. It takes a while to get in there and navigate it and understand what's going on, but I would advise you start with the favorite starting point for me, which is research, statistics, data, and systems. This is just a screenshot of the top part, but you can scroll down and there are, I don't know, 100 links through the down and categorized into different categories. One of them you'll see here is data.cms.gov. So that's the CMS publicly, or some of the CMS publicly accessible data. You'll see they also have COVID-19 data products available. And then you can see a little bit about Medicare beneficiaries, so who they are. So that's more sort of summary information. If you scroll down on that page, on the right-hand side, and I forget the high-level category, but it's something related to data, there's a whole wealth of publicly accessible data that's linked from there, focused on, say, Medicare Advantage and Part D, so this benefit design data that I already talked about, the enrollment data, the service area data, more information about the insurers. So who are the insurers? Who are these insurers? Where do they operate? Do they have sort of sub-levels to them? We've had a real problem on some of our evaluations where it turns out there's sort of the company at the very top, like Humana, but then they also have sort of subsidiaries that are operating the plans directly within the specific area of the country. And then finally, the Part D formulary and also the network data. You can also access information on providers. So these payment and spending databases, which are rolled up to the provider level. There's national plan and provider enumeration system data, so NPAS. So where exactly are these providers located? What is their specialty? How long have they been participating in Medicare? And then finally, for those who really care to read, very detailed Medicare regulations, which I don't necessarily advise unless you have insomnia. The fee schedule information can be kind of interesting if you're interested in seeing how much Medicare has said it will pay for specific services. Then there's this sort of other category of data, the quality data that I referenced, those star ratings, which exist for the Medicare Advantage plans and Part D plans. They also exist for providers. So there's the merit-based incentive payment system, which is generally primary care clinicians, and they submit data on their quality of care provided. And all of those data are rolled up and provided publicly, so you can see how the different providers rate and how they compare to each other. And then there are a variety of dashboards which are available on that data.cms.gov. So there's information on Part D drug dispensing. This was part of the so-called Sunshine Act some time ago. So you can see what provider was most likely to have dispensed a certain kind of Part D drug, and did they receive manufacturer payments related to that, for example. I think that's gone down quite a bit in recent years, maybe associated with that transparency. So then there are some really interesting research questions you can start to get at with the publicly accessible data. So what are the most frequently dispensed Part D drugs? Has that changed over time? How have provider payments and utilization of specific services changed over time? And then how do different providers perform on a range of quality metrics? And does that vary across the country, for example? So then the second category is this limited access data, which CMS calls the limited data set files, and they require some more effort and cost. You can still get to this link from that research statistics data and systems main page. You scroll down and it's kind of on the left about how to get data. But I went here to show you this. These data may be sufficient if your question involves a single site of care. So I'm really interested in inpatient stays and how they've evolved over time. Because the LDS data are stripped of any variables that could enable you to identify a given beneficiary. So you have information, this beneficiary stayed in this hospital on these dates, and this was their diagnosis, and here were the costs and so on. but you don't know that it was beneficiary A, which means you can't take beneficiary A and then go see if after they were discharged from the hospital, whether they had a Part D drug dispensed to them. So if you're interested in something that just focuses on the inpatient care, that's great. But unfortunately, if you need to crosswalk across different of these claims data sets, you need to go for the research identifiable files. But, you do get to see utilization and other data related to specific stays and visits as part of these files. So some potential research questions, how much do different cost centers in a hospital charge for inpatient care for Medicare beneficiaries? So for example, anesthesiology or radiology or the lab. How many beneficiaries receive different types of services during an inpatient stay? Okay, so now to the stuff that gets me up in the morning excited about my work after I've accessed the files. First you have to access. So the research identifiable files require substantial time and effort to access. This is the same. So you go from the research statistics data and systems, you scroll all the way down. It's kind of on the left. It's this files for order general information. And then it clicks you over to the resdac.org link, which I'll talk a little bit more about in a second. So a deep dive. Okay, so you have a great idea. First, I would say match your idea to the level of data that you need. We talked about some of the different uses of the different levels of data. So if you can use the publicly available data to answer your question, great, do it, you're done. But okay, say you need the research identifiable files. Finding funding is often a first step, right? So for many of you, you might be thinking about going to National Institutes of Health or some other grant-making organization. What you may need as part of your proposal is an estimate of the cost to acquire the data. So the Research Data Assistance Center, or ResDAC, is a organization that's contracted to CMS to help you through this process. So not only getting your cost estimate, but also through the whole process of getting the data use agreement set up with CMS. They're actually quite wonderful and very helpful. So they're your one-stop shop for obtaining the CMS RIF data. So this is from the homepage. It's just a first top section, but I highly recommend going and exploring this website. It gives you information on how to get started with CMS data, on submitting a request for the data. You can also read some really interesting, neat articles about the CMS data. So, some quirks that they've discovered and how researchers handle different problems associated with the data. My favorite part of the data, they have the data dictionaries up there for all of the different data sets that you could possibly ever want. I was actually putting together the cost estimate I'm going to show you in a second for this presentation, and I discovered a data set I didn't even know existed that we were just talking about. Wouldn't it be great if you could link the Medicare and Medicaid beneficiaries, the duals, and look at their utilization? And it actually looks like that data might exist. So thanks everybody for inviting me today, because I found something new and cool. So step 1A, decide on your cohort and match the budget to the data costs. So the data costs are going to vary based on what you're requesting. So the more years of data you request, they usually charge by year. The file types you want. So for example, inpatient versus MedPAR. And I can never remember what MedPAR stands. It's like Medicare Provider and Review something. The inpatient data are the extremely detailed line item inpatient stay data, and they're very, very long and detailed. They provide you everything that you could ever want to know about what happened to that beneficiary during that inpatient stay. They can be very useful if you really need to know the details, were they administered this particular drug, for example. But MedPAR, on the other hand, rolls that up to a higher level. So they give you a lot of detail on the stay and the diagnosis and some of the procedures, but it doesn't provide quite as much detail about everything that was done to the beneficiary, and it's cheaper. So then you need to think about your cohort size. So you can request a 5% sample. For some of the Medicare claims data, you can request 100% sample, but for others, you can only request 20% no matter what. You can't do it, unless you're working on, say, a contract for CMS where you can get access to all the data you want. You can also design a special cohort. So the project that's tied to this paper I mentioned earlier is actually looking at beneficiaries who've been diagnosed with opioid use disorder. And so we designed our cohort to be beneficiaries with any diagnosis of opioid use disorder between the years of 2013 and 2020. And so long as you don't hit that 20% sample, and very fortunately, there aren't as many as 20% opioid use disorder beneficiaries, then you're okay. You know, CMS is fine with that. So you can choose to purchase the data and have it shipped to you. But you can also have the option to use what's called the Virtual Research Data Center, or VRDC, which is where you purchase a seat and a programmer or somebody who's working with you who's going to be the person accessing the data logs onto the system and is able to work with all of the files that you've requested access to. It provides access to many data sets, but it's a fairly high annual fee. So I think the last time I looked at it, the initial year fee was $38,000 for one seat. I see people going, wait till you see the single year estimate for shipping data. And then the follow-on years are cheaper. It's like 25,000 or something like that, but that does give you access to the broad range of data. It does limit you though. It means you can only have one person accessing the data for that seat at any given time. And there's also problems related to merging those external data sources up into the VRDC. CMS doesn't really like that. And then what data can you pull down to actually be able to do analyses? CMS doesn't really like that either. So I've actually never worked on a project that uses the VRDC, but I wanted to mention it as an option so people are aware. So to obtain a cost estimate, you complete a specifications worksheet and submit it to ResDAC. That's if you need an official cost estimate for like an NIH grant proposal, and you need to say, okay, this is what ResDAC has told me it will cost. You can also get sort of a ballpark estimate while you're still thinking about what you want to do. If you go to the Chronic Conditions Warehouse website here, which Chronic Conditions Warehouse is a sort of database centralization area that also manages a lot of the data delivery for ResDAC and so on. It's a pretty cool tool. It allows you to estimate your cohort or select your cohort and then select all the different years of data and different data types that you want and get a cost estimate. Keep in mind, before I show you the next slide, that one way to make data access almost infinitely easier, not infinitely, much easier and much cheaper, is to reuse data from another project that has the data at your institution. So this is submitted to ResDAC and CMS as a reuse request, and it has a $2,000 annual fee. Keep in mind that $2,000 before I show that. The other, if you're working on a dissertation and you want to access data, I think what CMS still does, they did it for me for my dissertation, you can reuse off of an existing project at your institution and they waive the fee. So you don't even have to pay the $2,000. So that's nice for those working on dissertations. So an example cost estimate just for a random Part D project using a 5% beneficiary sample for 1 year, 2021. Yeah, you can read the bottom. I won't like why. So they split Medicare claims into a variety. I've grouped into other. There's like 3 other different categories that are useful to have. You can see carrier data, which are the Part B, as in boy, professional claims is by far the most. And then the Part D event data are quite a lot as well. So that's for 1 year. And I tend to do projects where I want like 8 or more years of data. So multiply by 8. Some of the biggest checks I've ever had to write, you know, out of my own grant, right, you know, is for data. Okay, so you've gotten the cost estimate, you submitted the grant, you got funding. Now you get to get started. So upon receipt of the notice of award, you can begin the data use agreement process. So when I'm submitting proposals, I usually estimate a 6-month time frame to obtain the data. I always find that I undershot it, and yet I always have high hopes. Maybe I'm a glass half full person. It's always taken longer. It usually takes about a year or so. So it's good to estimate quite a bit longer runtime. When you're getting started, you've got your notice of award in hand. Oh my gosh, where do I even go? ResDAC, back on that first web site, their homepage, in the middle one, they say they have a request forms generator. And so you go on there and you fill in, here's all the data I want, here are the years I want, do I want Part D, do I need these other things, yes, no. And it then spits back out at you and says, here are all the documents you have to fill out as part of your initial submission for a DUA. So constructing the initial request forms, depending on the data you're requesting, you'll have to fill out a variety of forms. The main one that I think you always have to do is like the executive summary, where you provide the background on your grant, what questions you're answering. You also have to justify why you need access to the RIF data and why you can't use the limited data set data to answer your questions. So you have to be prepared to say, hey, we need to link beneficiaries across these different files to track their utilization across different sites of care. And in order to do that, we need the RIF data. Then you also have to fill in a series of specifications worksheets, which detail the files and years requested, and if applicable, the cohort to be drawn. So for my OUD thing, actually we drew it, but that's a different story. We want beneficiaries with any OUD diagnosis between these years. Here are the diagnosis codes to use. For Part D, you actually have to go through a specific worksheet that lists all of the Part D variables, and you have to justify why you need each one. And you have to indicate the threat to your project of not getting access to that particular variable. And that's because when Part D was initially passed, these data were not actually accessible to researchers, and CMS was able to make them accessible, but they have to be especially careful with what variables they release. You'll also need to submit proof of Institutional Review Board, IRB approval. Lately, I've also been having to submit proof of a waiver of consent. I'm not going to go out to all of my 2.1 million Medicare beneficiaries and get consent to use their data. And they understand that, but you need to ask the IRB to give you that waiver. I would anticipate this step to take 1 to 2 months, depending on what other competing demands you have. Then you submit the forms to ResDAC for review. They're going to review your forms for completeness and accuracy, and I would expect a series of exchanges with them as they help you finalize those forms. So some changes that might be needed is revisions to any planned reuse approach. So this last process I went through took a year because we had planned to reuse data off of a project that was already reusing data. And you can't do that. You have to use reuse data off of the original project. So fortunately, we were able to reuse off the original project, but that's not what we expected. You might also have to provide further justification of the data or variables needed. They might think that your explanation of why you need the RIF files is not quite complete enough, so they're going to ask you for a little bit more explanation. So because of this reuse problem, on my latest project, I would say this step took 6 months or so. It was a lot of back and forth with ResDAC. Once ResDAC approves your forms, they go to CMS for review and approval. And usually this takes, I think they say 6 weeks. I would say 1 to 3 months. Usually at this stage, you're in pretty good shape. You're just waiting for CMS to say, okay. The hardest part is going back and forth with ResDAC because they're the ones who are administering this for CMS and making the determinations over whether your application is complete enough. So CMS doesn't tend to come back with much at this stage. Once CMS approves, they issue you with an official DUA approval email and a cost invoice. It's one of the nicest days. It's oh, we have a DUA. You pay the invoice, you follow the instructions to access the data, and you're off. You can actually start doing the stuff you wrote the grant for. So just to kind of wrap up, and then I'll open for questions, then I'm sure people are eager to get to lunch. Some tips to help you along the way. The first and foremost, and I have to remind myself of this, and deep breathing and so on, be patient. You will get there. It takes a while. It's crazy somehow, sometimes, all of the administrative stuff that they make you jump through in order to get there, but you'll get there. And that's tied closely to the second one. Ask questions. ResDAC is actually very helpful. They are there to help you succeed. I have sent emails to they have a general email address on their website, and they're very responsive and very helpful. Then, as noted sort of throughout, consider whether your research questions can be answered with other forms of data instead of the RIF files, given how long and how expensive it is. And then finally, make use of the websites. Another plug, I think that the websites are terrific. They're hard to navigate when you first get into it, but they're very informative. So this couldn't be a transparency conference, and I could, try to get away with without talking about transparency. I would say that CMS has increased transparency and access to their data in some ways over the last decade or so, but they actually have limited ability to go much further. So on the one hand, the public access files provide a wealth of information and enable you to really dig in and start to understand the Medicare program and its beneficiaries and its plans and providers. And in addition, these more recent new releases of payment model data as public use files and so on have taken a nice step in enabling outside researchers who aren't part of the evaluations themselves to really get a better feel for what's going on within the models. But on the other hand, CMS is bound to protect highly sensitive beneficiary data. So their sort of core mission is to serve and protect the beneficiaries they serve. And they do not want any inadvertent release of sensitive data that might enable somebody to identify a specific Medicare beneficiary out there. And so that's why they make you jump through all of those ResDAC hurdles in order to get access to those data. But they have increased efforts over time to create and release these limited data sets, which might strike a balance. So you get more detailed claims type information, but you're not able to identify beneficiaries. So I actually practiced a little bit this presentation earlier this week with a couple colleagues who were nice enough to sit and listen to me jabber on about something they already know a lot about. And one of them was reminding me that another colleague of ours often talks about the government's role in making data, collecting data, gathering data, and making data accessible. And I thought that was a really important point to note. So I think CMS's role here and other, data sources or administrative data types that you all have been hearing about during this training, their role is to collect these data and then in turn make it accessible to researchers like us and others to try to answer important questions and move society forward. So while accessing identifiable Medicare data is a long and complicated process, CMS has also made a range of data sources and types available with different levels of access. And for those seeking these identifiable files, well-tested and long-standing process has been established for researchers to follow. So while it is painful and it takes time, you can get through it and you can get access to these data. And I think that CMS, by and large, has struck a fairly good balance in ensuring that people do have the opportunity to access the data while also protecting it to the extent they need to. And then, of course, researchers have substantial support along the way in the form of ResDAC, for example, and potentially in the form of mentors that you all might have or others who are more senior who've been through it before. So with that, I will wrap it up and thank everybody, and I'm happy to take questions.